But anyway, well, thank you for coming today. It's my pleasure to introduce our Grand Round speaker today, Dr. Ivana Kawikova. She is a physician, and correct?
I graduated from medical school.
Yes, so she graduated from medical school in the Czech Republic, and she also received a PhD in pharmacology while studying in Sweden and London, and came to Yale to study immunology with Phil Eskenazi. And she's works in physiology and clinical research, working with Jim Leckman. And she also has training in neuroscience with Nigel Bamford. So it's really a pleasure to have someone here today who's going to bring in some very diverse areas of clinical research to inform how translational psychiatry and immune therapy can come together. So with this, join me in welcoming her to the podium. Thank you.
Okay, so let me first see that it works. Do you hear me? Yes. Okay, great. So thank you so much for giving me the opportunity to speak here today. I have worked for many years with Child Study Center, but I think here in the Department of Psychiatry, people in this incredibly diverse department are also very biologically oriented. And there are things that I have been thinking now for many years, and I would like to check with you what you think about it, and have some discussion and reach out to this audience. I think the room is not so big, and there are not so many people. So I feel completely all right if you just if you don't understand something or I don't say it clearly. Just let me know so that we can discuss, because if one person doesn't know something, it means that I probably didn't come clearly with my message. And if one doesn't know it, then there will be at least 10 others. So please do not hesitate, as we are going to talk about immunology. And despite that neuroimmunology is now a hot field, not everybody knows basic terms. So let's just get the communication straight. So I will talk about possibilities of immune therapy in psychiatric conditions. And I will kind of outline things from several perspectives rather than going into great details. But you can ask, actually, why are we asking about immune therapy in psychiatry? So the reason is, psychiatry, in my opinion, is really absolutely unique field. You have understanding of human being and human behavior in such a depth that very few people on the planet do. In the same time, the behavior is a result of functioning of nervous system, and that is very closely related to endocrine and immune. And we don't necessarily understand the interactions, the big picture of the interactions of these three regulatory systems that then result in different behaviors. So why is it important? It can bring new therapies. As an immunologist, I'm hoping that some of newly appearing medications will be helpful to psychiatric patients, and some other may at least improve efficacy of medications. I have been quite surprised when I found that the efficiency of drugs, the huge number of drugs that exist in psychiatry is ineffective in a large number of patients. Some people say 40-50%. I don't know whether that's right and whether you would agree with me, but that's the information I'm operating with. So if they don't work, that means we don't understand something. So I'm hoping that with better understanding of the human body as a whole, we can get better view. It can also, once we understand the interactiveness of these regulatory systems, we may have a better understanding why there are so many comorbidities. Comorbidities in psychiatric sense, in CNS, in relation to different presentations of conditions, but also around the body. When you look at some reports from autistic patients, they are practically very sick children, having many in hospital. They are coming to different departments because they present much more with GI, with respiratory system, with skin issues. Basically, the body is not in the right balance. So today's talk will be about the role of the immune system in psychiatric disease, looking through Tourette's system as an example. I will then touch on immune therapeutics. We're still quite far from really using them rationally. And then I will introduce the novel regulatory system of exosomes. Some of you might have already heard about it, but it's a system that we, again, very poorly understand, and that enables our cells and organs communicate, and also enable communication between all of us as we are sitting or standing in this room. And then I would like to talk about novel clinical trial methodology, because I keep talking to a lot of distinguished people here about adaptive clinical trials. And the only person who actually knows or reacted in a way, oh, I know what you are talking about, I'm doing it, was Roy Herbst, in the chair of oncology, meaning this is actually not surprising because the new methodologies came from oncology field. So what motivated me to actually pay attention to psychiatric conditions as an immunologist? And that was a case of a brother of my best friend in Prague, who was in medical school. He was 22-year-old, really easygoing person, who was dealing with pressures very casually. He was going through some medical through examinations in medical school without any major stress. And then at certain point, he had sore throat infection. He was diagnosed with infectious mononucleosis, and his problem started to develop. He was complaining about paresthesias shortly after the infectious mononucleosis. This actually gave him the label of hypochondriac among the physicians in Prague. He had developed severe obsessive compulsive symptoms that were so severe, or they were progressing into such a severe stage that after 6 years of medical studies, our medical school is 6 years, and in the last year, you already know who is going to pass all exams, and he was at the top of list. He was so compromised that he was unable to go to last single exam because of his high level of anxiety, despite that all professors were basically welcoming him, just trying to get him into the room to initiate discussion that would be the exam. So after 6 years of being excellent student, he didn't complete medical school, and after a couple of other years, he developed psychotic breakdown, which eventually developed schizophrenia that was not responding to any medications. Over the years, the approach was quite unsystematic. I then asked his father to persist that his samples are frozen and that we can eventually look at it from distance and see a different pattern. The samples were frozen, but then quickly used and in a way that they were not properly aliquoted. And basically that exercise was pointless. And I have seen this over time, that proper handling of clinical sample is a big issue. It requires a good organizational skill, one freezer, one backup freezer, and one single person that goes into a freezer and checks every sample where it goes. It seems trivial in light of all what we are doing, but it's not happening. But in any case, he had elevated IgM in CSF on several occasions. The immunoglobulin M is usually present in early immune response, and then eventually it develops to immunoglobulin G. And so nobody knew what to do with him. We just knew there was something related to infection, something that was off with immune system, and he was just going from bad to worse. He's currently on clozapine, and he still continues to have hallucinations. So for a long time, I was wondering whether infection could trigger psychiatric condition, at least in some patients. And my feeling was for many years that nobody really knows. And I wonder whether any of you encountered a patient where you would think maybe there was some activation of immune system, allergy, autoimmunity, or infection that preceded the symptoms. Did anybody? Okay, so some people are nodding, so thank you. But only few people, so it's not as common as you could get impression, I think. It's probably only a subpopulation of patients, but in the same time, it can be also because we are not looking, we are kind of blinded. So I was working in immunobiology department with Al Boswell, and I was having really cool project. I was looking at the role of immune system, a role of metabolism in human immune responses in humanized mice. I work with fantastic people, and it's one of those, the first project you define yourself. You sit through nights and you read thousands of abstracts to understand it, and then somebody wanders into your life, and that's Jim Lekman. And Jim Lekman was looking for an immunologist who actually would be willing to address the question whether post-infectious autoimmunity may play a role in Tourette syndrome. So I had here this great project, and I had this project that bothered me, the question bothered me for a long time. So I took both. And it was a very exhilarating time of my life. And working with Jim, you know him, so he's fantastic. He is kind, open-minded, and thorough. And so I hopped on the train of longitudinal studies that he was working on. He had 3 longitudinal prospective multi-site studies, which involved patients with very good clinical characterization. Only at that point I learned that there are no biomarkers in psychiatry, that everything is done on painfully formulated scales, and that there is a strong strive for objectivity, but these scales are still semi-objective. So these were patients that were as good characterized as I could hope for. And for me, coming from outside of psychiatry, I was excited that the symptoms include motor symptoms, something that I can see, even I, as an outsider. It also implied that there may be something with metabolism, because there's probably something hormonal where the predilection is for boys in quite overwhelming ratio. It also suggested that this is a developmental condition and that it may be something functional, not just that something gets damaged and stays that way, because the symptoms in Tourette syndrome wax and wane. And also, there was already at that time clear that it was involved stress. So it seemed like there's a big bag of clinical problems that somebody was trying to digest. And Jim recruited also at Kaplan, which is internationally recognized streptococcus, who was very particular about the way how you define that a child had streptococcal infection, so that we can actually find out in that prospective study whether the strep was there or not. The reason why this was very important is that many of us has strep right now in the throat, but nothing is happening. We are just living with it, or we at least think nothing is happening. So having Ed on site was also very, very nice. So our initial, why we actually saw that there might be post-streptococcal autoimmunity in Tourette syndrome. There was an increase of cases in offices in Rhode Island in late 80s, early 90s, where the patients had more streptococcal infections, and that correlated with presentation in psychiatric clinic with TIC syndrome. Then Sue Swedo from NIH did plasmapheresis on these patients, and also did imaging and saw a decrease of basal ganglia volume. So that suggested that if you remove some antibodies, the child or the local site where the pathology is likely happening is improving. So that was a big step forward. But there were then few experimental studies that were trying to jump into the field and find really the final thing, the auto antibodies, and not surprisingly, there were equivocal results, not because of the fault of the researchers, but because of the nature of the problem. So if you, so let me just now, I'm coming to immunology, and some of you had it long ago, the course, and some of you maybe didn't have at all. So I will use a couple of terms that I wanted to make you familiar with. And so here's immune response in a nutshell. We have, so we have innate immunity, and we have adaptive immunity. Innate immunity involves primarily macrophages and neutrophils. And the way how I talk to students about it is, this is like a carpet bombing. The cells quickly arrive, particularly neutrophils, and they start throwing away their explosions, their explosive devices, their enzymes, and destroy the tissue. But they destroy also the pathogen, presumably. Adaptive immunity is much more sophisticated. There is a specific recognition that the cells have receptors that specifically interact with certain antigen, and once the immune response occurs, it's silenced down, and then there is a memory response. So second time, the response is much stronger. And the adaptive immunity are represented by T lymphocytes and B lymphocytes. So they have T cell receptors and B cell receptors, and let's say if I have one microorganism, it can have multiple sites, multiple binding sites, and each site is recognized by one cell. And when that stimulation occurs, this cell starts replicating and produces a clone to induce a strong immune response. So you see it here in this picture, an example on the level. The example is the level of antibodies, so B lymphocytes. So you stimulate, and you have an antigen A. You get a response. You get certain level of antibodies in the serum, and then the response is silenced down. Second time, you do same antigen, the response is much higher and much faster. If you do a different antigen, it has to go through the process as the first antigen. So it's not unspecific stimulation. And what is also very important is that you see that at certain point, the response starts going down. The T lymphocytes now want to stop, because if the response was going on and on, there would be similar destruction to what we saw in adaptive immunity. So, and this is possible mainly due to subpopulation of cells that are called regulatory T cells, which are very, very tiny, about 3% of all T lymphocytes are the regulatory T cells, but very important here, because if you don't have the switching of mechanism, then the immune system is affecting it's destroying its own body. So here you see it once again. So there is an antigen. The naive lymphocytes meet the antigen, extracellular, usually the extracellular bacteria, or naive T cells meet antigens through macrophages or dendritic cells. These are antigens that get intracellularly, and only piece of the protein gets presented to the naive T cell. So then there is a clonal expansion. The antibodies are producing, and effector lymphocytes are producing cytokines, molecules that are enabling interactions and help help other cells in their interactions. And then eventually the response goes down, and you have now a lot of apoptosis going on, and only few memory cells survive until a second antigen comes, and those memory cells are now activated and produce a much stronger and much faster response. So why infections would cause autoimmunity? That's still a big question in immunology, because what is actually still unresolved is how does immune system really decides that the immune system should continue with its response, or it should shut it down? Did I already clear properly the pathogen, or if I shut it down too early, I don't clear it properly, but if it's too late, then I damaged everything around. So during the development, the autoreactive T cells and B cells are eliminated. Okay? So if you have the macrophage that presents antigen to T cell, or extracellular pathogen that is presenting to B cell to produce antibody, if it's self-antigen, there is no activation. If it's a foreign antigen, this is all stimulated. The problem is that during the elimination, during the development, there are lymphocytes that respond weakly. And again, there is this biological decision process where you have to, you try to keep as broad diversity, as broad spectrum of lymphocytes that respond to different pathogens, to different molecules, while preserving the self, the organism. So some of the cells that respond weakly to autoantigens are not eliminated. And now when infection comes, if this antigen is similar to these cell-reactive cells, then the problem starts, because now these self-reacting cells slowly proliferate and produce autoimmune pathology. So now, let's say Jim came with the idea, let's look at post-streptococcal autoimmunity. And I wonder, what would you want to see as an evidence that would convince you that a disease such as Tourette syndrome is due to post-infectious autoimmunity? Anybody?
You need an infection.
You need infection?
An onset of symptoms after the infection.
So yes, so there is temporary association with infection. Not so trivial to do in clinical world, right? So that's why the prospective character of Jim's studies was outstanding approach. Anything else we need?
Antibodies.
Antibodies. What kind of antibodies?
Ideally, an antibody that's associated with the disease that recognizes something relevant in the host.
And I'm so glad Chris spoke, because he's trying to find those auto-antibodies, right? So, yes, so what you want is you want some temporary association with infection. You also want to see that the infection was cleared, right? And that the autoimmunity is occurs after the infection is actually cleared. Then you want to see an inflammatory infiltrate at the site of pathology. So in our case, in striatum or basal ganglia in general. And what Chris said, you want to see that there are autoreactive B cells or autoreactive antibodies. And they can be B cells or T cells, autoreactive. T cells are much harder to prove. Okay. Now, and this is, even that is not enough, because you also want to see that these autoreactive antibodies, the antibodies that bind to certain place that you are interested in, that they actually do something. They activate something, they inhibit something, they damage something. If they don't, then they are autoreactive, but they are of no clinical consequence. So, as I mentioned, Jim was running those prospective longitudinal studies where he was inviting children with Tourette syndrome, or with chronic tick disorders, with OCD, and these children were evaluated for clinical symptoms through the white box and YGTSS scales for symptoms of obsessive compulsive disorder and the Tourette syndrome. And he also had the children to have taken throat swab, and they had blood taken for antibodies that are commonly associated with streptococcal infection. So that was a prospective analysis of trying to see the association between symptoms and infection. Now, we didn't know this as we were working, but at certain point, there was analysis done, and there was no correlation between symptoms and streptococcal infection. So I don't know how many of you know when you work very hard for several years, and then your results don't turn out as you thought. But then we were thinking about what could be happening. And the children were taking antibiotics for ethical reasons. You couldn't not give them antibiotics nowadays. The other thing is that the whole study was so focused on streptococcus. We now know that there are other infections that are involved. And this is now reflected that the acronym that was used as pediatric autoimmune neuropsychiatric disease associated with streptococcus is changed into pediatric acute onset of neuropsychiatric symptoms to reflect that there are other bugs than streptococcus. Further, more detailed analysis revealed that there is impact of psychosocial stress, and that has been assumed that actually the stress is more severe if there was a preceding streptococcal infection. And this is a theme also that is not completely resolved, that it seems to be infection together with stress that tips the balance. Now, there was also, we also found that the streptococcal infection had a newly diagnosed streptococcal infection were worsening the tic and obsessive-compulsive symptoms, but the number of patients were actually not quite convincing. It was significant, but no, you didn't really know how important this might be clinically. But then came, last year, came this Danish nationwide study, and that showed, this was analysis of medical records where they had a large population of patients. We see that there was over nearly 350,000 children who had now positive streptococcal results. And when they did association with mental disorder, they found an increased risk, particularly with OCD, it's 1.1, and tic disorder. So there is increased risk. Does every child with streptococcal infection get psychiatric disease? No. But there is a population that is more prone to it. And the same study also highlighted that it's also non-streptococcal infections to a lesser degree, but they are also non-streptococcal infections are involved in the or are associated with mental disorders. So in clinical world, you can't really do everything as perfectly as you would like, maybe if you are trained in the lab. But these data were for me sufficient to believe that actually strep, at least in some patients, is associated with onset of tics and OCD. Now, the other issue was, okay, if there is strep, but how does it do it? It's is the infection parallel? Is the child just feeling sick and then starts having some symptoms? Or is there really an inflammatory infiltrate at the site of pathology? So Flora Baccarino reported that there is a decreased number of paravalbumin and cholinergic interneurons in the striatum in patients with Tourette syndrome. And when I looked at it as an immunologist, I was like, yeah, okay, this is because these cells are destroyed by immune system. So that motivated me to struggle for 2 years to get some tissue for postmortem specimen from patients with Tourette syndrome. And I was hoping to see something like that you see infiltrate, perivascular infiltrate in the brain tissue. Little I knew that, and we saw it in one patient. We had 4 patients and four controls, and it's like teasing you, like you really want to find it, and you find it in one, but you keep struggling. And so we fought with it for about a year, and then we nearly gave up when Astrid Morer came to lab, and she just said, "Oh, why don't we do the expression analysis?" I was like, in these tissues, like your immunohistochemistry should be easier. But then we found a kit that allows analysis of the RNA in formalin-fixed tissue, and so we perform this analysis. So here you have the PCR cycles that are required for seeing a signal, but you may want to really see here the summary where it shows that we had increased level of MCP1, which is monocyte chemotactic protein, which is often present in chronic conditions. It's in acute, but it's one of the molecules that also stays in chronic condition. Then interleukin-2, which is a growth factor for T cells. It's produced by T cells, and it's required for T cells. And the CD45, which is on all leukocytes. So, and then there was IA2, which we don't understand why is it there, but interestingly, antibodies against IA2 are used for diagnosis of early onset of diabetes 1. The antibodies are often present before the clinical symptoms appear. So we sent the samples to Colorado, and there was nothing. So, but it's something maybe to think about. So we had now 4 patients. Very little, right? I'm not sure whether this would convince you. But fortunately, Flora is a really outstanding researcher. She took more patient samples, did whole microarrays in the tissues, and found a lot of data, but top upregulated module was showing immune system related genes, and to our excitement, it was TNF-alpha, IL-12, IL-6, and the IL-6 is very important for tipping off tolerance and immune response, and as you will see, these were of our interest as a sort of form of replication. So, all right, so we don't really see the cells being in the brain. That would require better collection of brain specimen, and I think a lot of improvements was done in this aspect. But mainly, we have an idea about inflammation present in this area through the protein expression studies. So, all right, so before we knew that there is some streptococcal infection, now we became convinced that also in the basal ganglia there is some inflammation. So then comes this little task of finding the autoreactive B cells and T cells that recognize some cells in basal ganglia that change the function or somehow damage the circuitry. Well, it's not so easy. And so in the absence of knowing where to actually, what to start, we focused on answering the question whether there is any inflammation ongoing in the patients. So we looked in the peripheral blood, and I actually think this is pretty remarkable that we looked at inflammatory serum markers. If you imagine that small area of in the brain, in basal ganglia, being possibly inflamed, spitting out some cytokines. And then we go and look at the whole body circulation, which is several liters. The dilution factor is huge. But we had nothing else to do than look at it, and then we counted the number of immune cells of the different populations, and eventually we also did immunoglobulin profiles. So what we found was that the patients with Tourette syndrome have elevated level of TNF-alpha and interleukin-12. So these are cytokines that are very important for T cell immunity, particularly for certain subsets called T helper 1, which is, for example, present in viral responses. And interestingly, because Jim, as he had the longitudinal studies, we could look at what happened, what were the levels during pre-exacerbation and post-exacerbation, and whether they differed during exacerbation. And you see that both TNF-alpha and IL-12 got higher during exacerbation. So now the cells. So we counted different subsets of T cells and different subsets of B cells. And the most interesting was the subset of regulatory T cells. It is the one that is stopping the immune response. So here you see a Fox plot where we first gated on T cells and then looked on CD4 cells, which are the T helper cells, and gated on CD25. At that time, we didn't know yet that there was typical transcription factor FOXP3, but we now know that it correlates nicely with high level of low affinity interleukin-2, which is the CD25. So we focus on this population, and you see here the numbers in healthy, in patients with mild Tourette syndrome, and patients with moderate, and you see that the number of regulatory T cells is decreased. It also decreases during exacerbation of symptoms. Why? We have no idea. Because the thing is that we are looking again in the peripheral blood. We don't know whether the cells migrated somewhere or they are just lower, and that might be actually the reason why the individuals with Tourette syndrome are more susceptible to autoimmunity. They may have the lesser capacity of that system that shuts down the immune response. So this was just to show you here that the regulatory T cells are important in reversing the immune system to quiet stage. All right, so now we know that there is inflammation and that the patients may have increased vulnerability to autoimmunity. Then there was actually one Christmas time when Jim called me to see one of his patients, a child that was 11-year-old boy, and he had very severe symptoms. He was shaking. I thought, not knowing the clinical picture so well, I thought he was in seizures. So parents were panicking because this was a very good child that was non-problematic, and he had some tics as a child, he had some streptococcal infections as a child, but now it all got over the board, and eventually this child progressed to schizophrenia that it was also for a long time very difficult to manage with medications. Jim gave me the charts and said, what's wrong with him immunologically? So I started to flip through, and he had obvious immunoglobulin A deficiency. And there was at the time when I started to look at immunoglobulins, and I was hoping that we are going to see maybe overactivation of B cells in autoimmunity, that maybe we see more immunoglobulins. And I saw little bit few in the lower IgA. And this case of this child made me actually think, wait, my God, this may be actually a real thing, this preliminary pilot data. So then we expanded, and we found that the children with Tourette syndrome in that group that we measured had decreased IgA, And as much as I didn't like the definition of pandas and non-pandas, Jim asked me to separate it, and to my surprise, the pandas group was actually decreased, even more than non-pandas group. So, so now we just said, okay, if the children have IgA deficiency, or maybe not full-blown IgA deficiency, maybe just reduced immunoglobulin, they may have a problem with dealing with the infections. The infection will be dealt with eventually, but it may slow down the clearance. And that gives the chance to bugs to produce all sorts of their molecules that are promoting their survival. And for example, exotoxins. And if there are increased exotoxins, there is a higher likelihood to get the immune response towards autoimmunity. So this was a small group of about 20 patients. So we expanded the group further and also collaborated with people from Groningen. We did not find IgA deficiency. There was IgA was completely okay in these patients, but we found several other immunoglobulin, isolated immunoglobulin dysgammaglobulinemias. I call it dysgammaglobulinemias because the reductions were about 30–40% compared to age-matched group. But if for calling something deficiency, you need to have a drop to standard error means from the mean. So you need two standard deviations from the median. So this is not full-blown IgA deficiency, but reduction in isolated immunoglobulins, meaning that these children are perfectly functioning, but they don't have the full capacity to respond to all the environmental factors. So, okay, so that's where we were with regards of proving that there is some association with streptococcal infection, that there is a sign of inflammatory infiltrate, and that the children have not big deviations in immune system, but some immune deviations that may make them prone to develop autoimmunity. So what would you do if you have a child that comes with new onset of severe tic disorder or obsessive compulsive symptoms, and you just know that the child had not too long ago, a couple of weeks, he had streptococcal infection. He was already on amoxicillin. So what to do next?
Consult with you.
I'm not licensed. So the silence that we just experienced, that's why I'm actually here today. Because I'm coming from clinical immunology section. This was the first place that I came to when I arrived to the United States. I have friends there, I have Phil there, and we talked and what to do with these children. And nobody can touch them because there is no proper diagnostic marker. There is no good reason to give them immunological therapy because you cannot justify it, and immune therapies also have adverse effect. So now comes Chris. So there is a big hope in Chris's lab. Actually, he was preceded by Madeleine Cunningham that was trying to do these functional studies, and she's struggling heavily with having too few samples. So she's commonly accused of overinterpretation. So so she's struggling in Oklahoma, while Chris really raised my adrenaline when he told me about the finding that they did on with samples that they had in patients that were treated with intravenous immunoglobulin. So IVIG was given, and then they had samples from people who did or who did have IVIG and who were post-treatment. So anyway, so he took the correct me if I'm wrong, but you took the serum samples, put it on the brain of mouse, and look at the binding. And the binding showed some big cells, and the big cells in striatum are a small population, about 2-3% of population of cholinergic interneurons. And so staining with cholinergic interneurons, staining the immunoglobulins, overlapping, there are some dots. Then they quantify the dots, and you see that children with PANDAS symptom had more of the dots. So that was cool. I was like, yeah, okay, whatever. But then I said, but they don't bind to parvalbumin interneurons. So that was okay. All right. So this is specific, very interesting. But then this resolves when the patients are treated with intravenous immunoglobulin. And I don't know what's going on now in your lab, but last time I spoke with Chris, he was talking about quantification of the signal, and also about expanding the groups to have really solid diagnostic marker. So fingers crossed. It's not an easy task. Would you like to comment on it? What would you like to say?
We replicated it using a different method in the same people, and then we replicated it in another 6 kids, independent cohort. And it replicates, and the resolution with IVIG replicates. And we don't see elevated binding to cholinergic neurons elsewhere in the brain.
Okay, that's another aspect that this was only in this area. So, but
we
because
might get an R21
it's fantastic, and but because we are scientists, so what? It binds. Where is the functional proof? So the functional proof would be very nice to see that the antibodies actually do something, and you are already working on it, of course. So the cholinergic interneurons are incredibly interesting cells in the striatum. They are large, few of them. Look at the network, the tree that they actually create next to each other. But why I think they are really, really interesting is that they tick like a clock. They spontaneously are discharged. And you already know it from some people who studied physiology. You may remember heart. And you remember that the heart has automaticity, right? And so these channels, this here, the spontaneous depolarization that is ongoing is similar here in the cholinergic interneurons, and this is mediated through channels called HCN channels, hyperpolarization activated cyclic nucleotide gated channels. So the ticking is, it's probably regulating a lot of things around it by just being regular. And if you stress it, maybe as a heart, maybe it beats faster, I don't know. But let's see what those antibodies that you are detecting, what they are doing to those interneurons. And they may actually, we were studying the cholinergic interneurons with Nigel in Nigel Bamford's lab. We were trying to see how depletion of dopamine is affecting this slope. And if you don't have enough dopamine, like in the heart, it's the slope is kind of tilted because the HCN channels don't open so frequently. Okay, so this was in Parkinson model with low dopamine, and if you reverse it to the Tourette syndrome, it could be that there is more dopamine and that they actually make the cholinergic interneurons beat faster, and therefore there may be dysregulation in circuitry that leads to uncontrolled movement. This is just a speculation. So, okay, now let's move the clock forward. Now, Chris already tells you we have these autoantibodies, and we can diagnose the patient who has the autoantibody, so we can select the patient. What can you do with such patient? So now you would get an attention of an immunologist, clinical immunologist. Now they would start talking with you. And actually, even without immunologists, there were already attempts to give intravenous immunoglobulin to the patients. Now, the results are so-so. Some patients benefit, some don't, and it needs a lot of clearing. But it's also not so surprising because IVIG is to be given to patients who do not have immunoglobulin, who have some sort of B-cell defect that results in a reduced immunoglobulin in their vessels. So this is great for B-cell deficiency. But most of us, if I now went and got IVIG, I probably feel much better tomorrow. And the reasons are not entirely clear. There are multiple mechanisms. One of them can be effect on regulatory T cells. Some of them can be because maybe the immunoglobulins that you are giving to the patient, the Y shape, has the FC portion, and it may sit somewhere on FC receptors and block certain areas that you would like to actually block. So this may be some unspecific effect. Now, more logical but technically more difficult, particularly in children, is plasmapheresis. Plasmapheresis is plasma exchange, and you basically, now you do something logical because you assume that you have autoantibodies, so you remove some of these antibodies through plasma exchange, at least percentage-wise, at least you decrease the amounts. Then there is rituximab, which is biologics that is affecting CD20, which is on B cells. And what it actually does is that you deplete the B cells. You give rituximab, B cells are depleted. But because the bone marrow of the patient works, or a bit better works, you wouldn't give it to patients with affected bone marrow. So the bone marrow works, and the new B cells are produced. So what you achieved overall is that you removed the memory B cells, because the naive B cells, they were replaced. The replacement takes about half a year. The patient is at that time immune deficient, but it's now done a lot, and there are known adverse effects, but it's also known how to handle these patients, how to cover them with antibiotics during the time when they are having limited B-cell responses. So, so this is one thing that if I was the clinical immunologist to whom you came, I would just say, let's try this, if it was a sufficiently severe patient. Now, all the biologics, all this vast number of antibodies that affect individual molecules in the immune response started with interferon gamma and anti-TNF alpha. You may have heard the name Jan Wilczek. So it was a Czech physician who came to the United States to escape communism, and he did this incredible change in the way how we treat patients with severe autoimmune conditions, such as rheumatoid arthritis or Crohn's disease. In CNS, however, there are reports that TNF-alpha is doing demyelination. So you may not want to go that way. So there are, once Chris produces the, so I'm sorry, I'm making you up. Once there are autoimmune antibodies defined, then the immune therapy can be considered, but with the view that every immune therapy, if you inhibit the immune system, there is immunodeficiency as a side effect. And that balance of benefit, risk and benefit needs to be taken into account. And I also think that we are going to really benefit from oncology field, you know, about the Nobel Prize this year that was given for checkpoint inhibitors. And the checkpoint inhibitors are exactly the drugs that are affecting the presentation of by macrophages to T cells. And this is the point where you decide whether the immune system goes on or it's inhibited. Now, not surprisingly, cancer people want to actually enhance the immune system. And not surprisingly, the adverse effect of checkpoint inhibitors is severe autoimmunity. So the balance is very important. So now, before, I was telling you how we're saying that autoimmunity is when the bug already is gone, it's cleared, but now the system can be sterile, but now the autoimmune antibodies are affecting the self-organ, our own organ. I saw this only 2 days ago. It's 1 month old news, so some of you might have heard it. And I think this is absolutely astonishing if it's true. Rosalinda Roberts from University of Alabama reported in San Diego's conference that actually we do have bacteria in the brain. She's not yet 100% sure, and she presented it in order to recruit collaborators who will help her to produce really strong data, but so far they identified 3 strains of bacteria, and she's an electron microscopist who saw all these vesicles or bodies for all her life, but she didn't know what is it until they actually tested what is it, and this looked like bacteria. She looked at patients with schizophrenia and healthy patients, and she sees them there. Then they looked at mouse brains from germ-free conditions. So it looks possibly real, but she needs to have absolutely strong proof that this is not a contamination. So this is basically happening. And now let's imagine that we have some bacteria in the brain and some other bacteria come. And some have to leave, some die. So the balance can be disturbed. But I think this actually opens a new way of thinking of the whole complexity of our environment and our bodies and our organs inside of our bodies. It also could be possibly an explanation why sometimes antibiotics have some effect in patients with psychiatric conditions. Definitely there are some publications for Tourette syndrome with azithromycin from Tanya Murphy in Florida. And I always thought as a pharmacologist, I said, okay, it found some receptor and it affects something. But it may be that the bacteria, the sensitivity to different antibiotics can change the balance of bacteria in our brain. And it also made me think again about a model that you are probably quite familiar with, was developed by Paul Patterson at Caltech, who took the pregnant mouse and challenged it with some immune activation. And now the babies are born and the babies grow, and the grown adult males have symptoms that are resembling autism symptoms and corresponding changes in mainly in Purkinje cells and cerebellum that were a long time standard, like the most common finding in autistic brains. Why is it that these children that were born to that mom in the adulthood still have these issues? Now, this model is not only a model of autism. Now it's schizophrenia and a lot of other conditions, because this insult and also different infectious insults in different endocrinologically vulnerable periods, they do things that people pick up as models now for different conditions. So in this model, there was a paper in Cell 3 years ago where they showed that the offspring had actually leaky gut, and that leaky gut was associated with the behavioral changes. And when they gave orally these mice a common human common cell bacteriotes, and the mice improved. So this again speaks that maybe the balance of bacteria, if it's true that we have bacteria in the brain, that this may play a significant role and may change the way how we are approaching patients. So I put here a picture of impressionistic picture just to bring you to a different area of thinking. I always liked Impressionists, but it was only when I entered the room in Clark Institute when it just hit me how novel thinking these people experience. That they were great painters, but all the beginning of 20th century, late 19th century, they just changed their mind, their way of view of the world. And similar feeling I had when I learned about exosomes, which will be the next thing that I will talk about. But before I do that, are there any questions on the things that I have discussed right up to now? Yes.
I'm trying to think outside the box.
Please do.
Looking at your painting there, it's beautiful. But does it make sense to experiment with antibiotics on otherwise healthy patients, meaning patients who are not exhibiting any symptoms of infection or fever, or just to see if there's any remaining?
I'm sure people will do that. I'm sure they will start with mice, probably. That's where I would start before taking some broad-spectrum antibiotic for myself. So you think that antibiotics given to healthy people, that's where you will start with your experiments?
May improve their psychological condition by impacting the bacteria that's still lingering in the brain.
So let me just say one thing. If I give you an impression that the bacteria are coming there on some occasions, from what Rosalinda Roberts is finding, it seems that we have the bacteria there all the time. Maybe not much. It's interesting that it's the common cell, so it's probably bacteria that also in gut we tolerate very easily, right? So if it's true, that finding, then we may have the bacteria all the time. Then the new bacteria may come and they may interact and they may contribute to some changes in the neuronal circuitries. And experimenting on people would be good, but if it's a healthy person, it may take more to tilt the balance. Yeah,
Uh,
I think it's an interesting thing. It's
Maybe interesting because
yeah.
people's psychological condition or their just well-being improves drastically after having taken antibiotics for 2 or 3 days, after following an infection. Obviously, that's related to the fact that the infection is under control and there's no fever, but it could also be that
I think
their
this.
mood has improved because of the impact on the brain bacteria.
Yes, and it. Go ahead.
I'm just going to interrupt for 1 second. We actually end around 11:30,
So I realized it. Can I say 3 more sentences just to run
you?
you?
You can. I just thought I would just.
Yeah,
give you-
I realized when I looked
Yeah.
at the watch, so I apologize for being late. But I just want to tell you what are exosomes. Exosomes are small, tiny vesicles that are produced by any cells and absorbed by any cells. We don't know why a cell decides to produce it, why it decides to accept it, why is the targeting. But it contains, it looks like this. It has interesting surface that is still under investigation. And as we are talking, we are exchanging exosomes that are having RNA and micro, the non-coding RNA that is affecting the translation and transcription in distant cells. It also has proteins, and it does a lot of things that we are not aware of. Phil likes this picture, that these are the interactions that we have through exosomes. Individual cells talking to other cells. And as I'm producing saliva, I'm sharing my exosomes with you as right in this room. To your question, this balance of the bacteria also produce exosomes. And the exosomes are shared between bacteria. So we are also incorporating into our genome content of exosomes from plants. So all these bacteria are, all these exosomes carry a lot of information, and we don't know much about it. Phil found that at some situations, the delivery of exosomes can be antigen specific. It can be given to in any way. It resists stomach. It can go. We can swallow the exosomes, and they will be okay. This oral exosomes is same effect as any other exosomes. And importantly for psychiatry, these exosomes can be engineered, and an intranasal administration of exosomes can, containing anti-inflammatory drug, can reduce the classic example of autoimmune encephalitis. And just a recent paper from this month showed that intranasal exosomes from supernatant of stem cells can reverse autistic phenotype in mice. So if you can just remember the word exosomes, and when you go home, as Phil says, just type your favorite word into PubMed, and next to it do exosomes. And you will see what comes out. A lot of information. So the exosomes are important, and now we have incredible complexity. And I'm showing you here a beautiful picture by Matisse, who just took several lines and expressed what he needed. He didn't have to paint every little detail. So I'm hoping that we can actually achieve that also from knowing in depth what's going on. And the last sentence, let me just mention this one word, and this is adaptive clinical trials. Adaptive clinical trials were developed through oncology, and compared to the previous clinical trials, the gold standard, 70 years old gold standard way of doing clinical trials, it allows interim analysis, and in that way it speeds up the way how the drugs can be delivered. It uses, instead of frequential analysis, it uses Bayesian statistics, and NIH is now actually approving the style of clinical trials that enable us to look at biomarkers as we do the work and speed up the way how medications can be delivered. I'm sorry to be over time. Thank you.